Hello and welcome to your basic report writing on New World. We're going to jump right in. When you're getting ready to write a report, first thing you're going to do is go to Incidents. If you notice that your bar doesn't look like this, you can go to Tools, Customize Navigation Bar. You can set the large icons. You can go over to Navigation Bar Components, set what it is you want to see and what you don't want to see. You can also create custom groups with the stuff you use most often. That's pretty cool. When that's done, you have the opportunity to make this a lot cleaner looking for what you use a lot. In any case, you're going to go to Incidents, and then you go to Incident Search. Once that opens, you have a few options. Now, if you just hit Search, what's going to happen is it's going to populate everything that there is. All the calls. It maxes out at 250 because that's how the settings are. You can change those settings. You're going to see all the calls. And then New World is going to have to return information on all those calls every time you change a screen. That slows things down a lot. That's not something you want to do. A great option is hit specific date. Then you're going to pick, hey, I just want today's calls. Perfect. Now you just see a small number of calls, and that's a lot less data for New World to deal with. Your next option is you can find the call that you want and put in the call number right here. So I 828, search, and then I just have the one call. That's the fastest that it can run. You're going to double click, open this thing out. Perfect. You're going to confirm that the station is correct. Sometimes the station that it's paged at is not the station that services the call, so you want to make sure that it is correct, and dispatch does make errors from time to time. You're going to choose the incident type. Our common incident types that you'll see a lot. 321 EMS call, 3211 medical transport. Then you have your motor vehicle accidents with and without injuries, plus a pedestrian accident. You have fire calls down this way and just about every call that you can think of. You choose whatever it is you think is most appropriate. We're going to do a 321 today, an EMS call, excluding vehicle accident. Choose the shift that you're working on. And then you're going to pick a few primary actions that you did. You have a lot of options from mitigating hazards, incident control, traffic control. What we're going to be doing is just basic life support and transporting a person, which is a common EMS call. Over here, you don't typically need to do anything in any of these on a general call. When you hit next, it automatically saves this. So you can hit save, but next will automatically save. That'll kick us up to the next tab, and it generates a few more tabs based on the call type that you chose. So if you choose fire call types, you'll get a bunch of different fire tabs. If you choose medical call types, you'll get a bunch of medical tabs, and so on and so forth. Next, you're going to decide if this is a street address or intersections, directions, national grid, things of that nature. Most things are not mixed use, but if they are, you would put that there. You'd delete the not mixed use and add some sort of a mixed use. In this case, the property that's 61 is a fire station. Your other options are things like a one or two family dwelling is a common one, a hospital, hospices. That's not what I was shooting for. Let's go find hospital. It should be here somewhere. 24-hour nursing homes, that's common. Hospital, medical or psychiatric, those are fairly common. In this case, it's a fire station. Then you want to make sure that the address is completely filled out, including the state, and directions if you need them, if it's a mile marker or something of that nature. Next, we're kicking over to incident times. On incident times, you'll see your dispatch generated times. This is when you arrived, when you controlled, and when the last unit cleared. Generally, there's not much to do here, but you do need to make sure that the appropriate times are in place. Special studies, this is where you would put any special information. It's not somewhere else on the report. Your options, transient person, we don't typically track that here. Permitted burns, that's controlled burn that have permits. This is the one we use fairly often when you do a flight crew transport. All we're going to be doing is marking who we did the transport for. Then number 4, it's an interfacility. You're just giving information on how long it was. Over 100 miles, between 50 and 100, and less than 50 miles. This is where we log if there's any reasons that the IST was canceled. They canceled it. We couldn't do it. Staffing issues, time of day, weather-related issues. Gas and oil incidents, we don't typically track that. System status level, I haven't seen that used very much. So we're not going to put anything in here. Next, we move to apparatus. So here we just have ambulance 61. Sometimes you will see a 6,000 or a 4,000. That is the unit that dispatch pages, and you can just delete that. Don't just delete the actual apparatus that responded, because then you lose all the times, and that'll really bum you out. You're going to double click that, choose the response mode, non-emergent, and then the actions taken specifically by that apparatus. They provided basic life support and transported a person. It's probably important to note, if somebody was canceled, you need to click canceled here and then cancel it around here. Otherwise, you'll get an NFIRS error. That's not what happened, so we'll put it back the way it was. Lovely. Next. We'll wait for a moment, which is something you sometimes do. Next, we're adding personnel. Now, very commonly, supervisors on shift will have the personnel listed in the New World schedule and attached to apparatus, but, oh, I'm sorry, we're going to times next. We'll come back to personnel. So you're going to double click this, open up the times, and these should be auto-populated, but if they're not, you would need to call dispatch, get the times for that. One of the things that's important, unless you called at patient when you arrived at the patient, let's see, we arrived 15:30, let's say. Then we transported. Unless you called at you arrived at the patient over the radio, you won't see anything here, and you should go ahead and fill this in. It should be shortly after you arrived on scene, typically. And then the transfer of care date is never put in, but you should also put that in. And that should be 15:31. Clear time, I'll put that as 15:32. This needs to be in chronological order. If it's not in order, you're going to get some NFIRS errors. Perfect. So note that these two are filled in because they transfer over to a lot of other boxes later on. Next. Apparatus personnel. So again, sometimes supervisors will enter this in, but sometimes it looks like this. And there are people who are not here, whether it's because of a trade or an overtime situation. So delete the people that aren't here. Leave people that are. If somebody's not there that was there, you're going to go ahead and hit new, go find the person. Personnel shift prompt leaves it confined to the people who are supposed to be on shift today, according to New World. Or you can open it up to everybody. Now you can click here and type a letter and get to the last names that start with that letter, which is quite fast. So if I click and hit C, I'll go to the C's, and then I can find the person that I want, save them to here, and save them to there. As far as assignment and actions taken by people, there's no need to fill that out at this time. So you do that for each apparatus that responded, and then you hit next. Person involved, this is if there's a party that wasn't a patient, or if you had just somebody that you took information from and needs to be attached to the call in some way. You're going to hit new. This is a process that you're going to see a lot in New World, and it's good to be familiar with it. You choose the type of person, whether it's an adult, juvenile, business, or other things. We don't typically use these. In this case, it was an adult. So we'll say it was myself. Unless you are at the person's home address, you don't want to leave this checked because it will limit the search that comes back to you. I think it's best practice just to uncheck it all the time so that you get the full picture. If you have the social security number, you can put that in. Then you hit the search, the little binocular. That's going to bring up all the versions of the global subject that exist. Then you're going to scroll over here, and what you're looking for is an FDID that is consistent with us. And so in this case, we are 04525. So that's here. And then you want to confirm date of birth and any other information that you have. If you have anything to update, you can update it here by opening this up, or you can just double click it if it all looks correct. And then it's attached. You say this is the owner of the place, save it in here, and now we have their information saved. Next, we're looking at authorization. This is a page where we mark who wrote the report and who was in charge of the call. Sometimes it's the same and you can leave that checked. Sometimes they're different. So I'm making the report, or maybe someone else was in charge of the call. Typically, the highest ranking officer on scene should be marked as in charge, even if they weren't necessarily the lead care provider on an EMS call, because they do have ultimate responsibility for everything that happened. Next, remarks. This is where you would put a narrative on a non-EMS call, just describing what happened, what hazards were mitigated, what actions were taken, what was found, typical things of that nature. It's not necessary to complete this if it's an EMS call with an EMS PCR narrative. This is a fire incident EMS. We're going to come back to that because it's a pretty involved process. If there are other documents that need scanning that are not part of your PCR, patient care report, this is where you would put those. I'll show you how to upload documents later when we're doing that for PCRs. We don't need to use review processing. You can through additional info if for some reason you need to gain access to the CAD narrative, computer-aided dispatch narrative. Here, she just generated a call for training, but if there's any information from dispatch, it'll be listed here. So now you're going to create a patient. Same process here, right? Again, remember, take out the incident address. Type the name of the patient. Search. Good. Now, this brings up a good question. What if nobody shows up? Number one, if nobody shows up, oh, look, it worked. That's kind of awesome. I didn't know it would do that. Let's make a more severe typo. Good. So really, if you have it incorrect, nobody will show up. So do make sure your spelling is correct. But let's say that this is correct and this person didn't show up. That means that they don't exist. What you're going to do is hit New, and then it will open up a screen. I'm not going to do it now because I don't want to make extra global subjects, but it'll open up a screen, ask you for the information, and then you'll save it, and it'll cancel out and create the person. So you are creating a global subject. Don't do that just all the time because it gets to be kind of cumbersome with a lot of data. Perfect. Double click. I found myself 04525. It's a CRFR global subject. You see that these two transferred into here? That won't happen, and those are required. So easiest way is to put them in up here on times, and then they transfer throughout the entire PCR. You can always just say the assessment was documented in the PCR. This is the highest level of provider on scene. So even if it's a BLS call, you put the paramedic on scene if that's the highest level that was there. Then either no treatment or the procedures were documented. The rest of these are not required. We don't need to do them. Then you hit save to save this person. If there are multiple patients, you repeat this process, patient number 1, 2, 3, and so forth. Now you're going to select this patient and hit the patient care report. This opens up the entire PCR window, which is the meat and potatoes of an EMS report. We'll wait for that to load. Now, while we're loading this, I'll just say that I always recommend typing up your narrative in a Word document as opposed to typing it in New World. For a few reasons. One, it makes sure that you don't lose it. So if something happens with New World and it loses some data, you don't have to start over. The other reason is that Word has a very excellent spell check and grammar check, and you can also put the Grammarly plugin on it to make it even better. So that'll work a lot better for you to paste it in, and I'll show you how to do that because it is a little tricky. So here, this should all be filled in from the global subject that you put in. Now you go to response. Complaint reported, whatever it is that happened, or the closest that you can find. We try not to use other if we can help it, so try to find the closest thing that you can. Injured. This is an important one. If you're doing an IFT, it needs to be switched to IFT. 911 calls get immediate. This is pretty much constant. They always do EMD, so you can leave that where it's at. ALS assessment. Again, if there was an ALS provider on scene, you can check yes to that. If there wasn't, don't. Apparatus. This will be the apparatus that transported or serviced that patient. Primary role is almost always transport, but in a refusal situation, it can be non-transport. This is where you would check medical transport or a flight crew transport or an intercept on the rare occasions that happens. 911 response is for your typical 911 call. Level of care, again, highest level available on scene, not necessarily the level of the lead care provider. These things pre-populate, which is excellent, and for the most part, you can leave them the way they are unless they're not correct. Location type, very commonly home residence, but you can end up in some other places. And there are a few places that end up in the public building section because they're not listed. If any of these are applicable, you can add them in. So normal traffic, unscheduled, this was a scheduled transport. We don't have automated lights change, enhanced speed if you had to do that. So we check number of patients, triage color here, if it's applicable. Mass casualty incident, if applicable. Residency status is fairly important, so that's if they're a resident of our district or not. Here, you're going to do the mileage. It's very much okay to put 0 on the first one, and then put whatever the amount of mileage as you calculate, typically using Google Maps here. Personnel, this needs to be everybody who was part of the patient care experience. So you're going to mark the driver, put their level in, and if they went to the hospital, you check went to the hospital. Primary patient. And essentially, anybody who was on scene should be here, and you can just put them as others. Didn't go to the hospital, don't check it. All of the people who showed up. This should be a record of everybody who was there for the call and assisted in care. That definitely happened. Perfect. Response times. This will be pre-populated with the data from out in the NFIRS section. You just want to make sure it's all there. If there were any delays, whether there was a delay on the dispatch end, there was a delay on the way out the door, delay on the scene, delay getting them transported, or delay turning around, you want to document that here and also follow up with more detailed description in your narrative. Situation, you're going to talk about the primary symptom. There's a lot in here, lots of options there. So you can pick something that works. Try to make sure the onset time is correct. Typically, the onset time defaults to when the call came in, which is very often correct, and that's okay. Then if there are more than one symptom, this is the primary one. These are associated symptoms. So if you have multiple other options, you can pick them. Seizures, urine retention, there's some great ones. Cramp and spasms. I get this all the time. Possible injury, no injury, yes injury, I don't really know. If you say yes, then you're going to get an injury tab. If you say no, you're going to get no injury tab. If you hit unknown, you're going to get an injury tab. And if this is open, you need to fill it out. This is your initial acuity. This is, again, with your triage colors. Primary impression. This is different than their primary symptom, and it kind of ties in with their chief complaint. This is what you think is probably going on with them today, right? So whatever you think is the primary problem. Work-related, yes, no. This is for work comp. Cardiac arrest, did they have it or not? If they did, was it before or after you got there? And this is the last known well date. When was the last time that they were okay, if that's something we can document? Secondary impression, if you think that there are more things going on, right? If you think the behavioral psych problem is because of encephalitis, you could put that. Patient activity, not reporting, that's totally fine. You can leave that there. Complaint, this is a pretty simple thing. You're going to hit new, complaint type, chief. No, we're not going to do that. That's not a very good complaint. We'll go with anxiety. Paranoia. Ooh. Is that how you spell it? I think it is. If only I had Microsoft Word right now. Oh, I do. Yeah, it was right. Knew it. Moving on. I'm sure you've picked up, so you have values here. So this has been going on for 1 days, hours, minutes, months, weeks, years. That can be an approximation. I'm sure you've picked up that yellow fields are things we're supposed to do. So not really applicable. Anatomic location for this complaint, organ system, it's a psych thing. Perfect, you're going to save it. If you want, you can do secondary complaints if you feel like that's something that you need to document, or typically this looks just like this. Injury, so we're going to talk about causes of injury if there was one. We think it was probably a hurricane in this case. Mechanism of injury, it was a penetrating thing. Risk factors, taking some Coumadin, and I just really felt bad about it. Trauma center criteria, right? There's a pelvic fracture involved, a penetrating injury to head, neck, torso, extremities. Ooh, bad. Use of safety equipment if it's applicable. I was just wearing the lap belt when it happened and I got hit by the hurricane. I was wearing protective clothing and a PFD though. Airbags, if they were deployed, you're going to mark that here. That's your situation tab. Cardiac arrest. Typically, if you're just doing a call that there was no arrest, you're just going to hit nope. That gives you your green check mark. That makes you feel good. But if there was an arrest, you're going to fill all of this out. Talk about what your initial rhythm was. VFib, or we don't really know what happened. Maybe it was exsanguination, they were bleeding, they drowned, respiratory. Oftentimes it was presumed cardiac. Whether this was witnessed or not. So say the witness saw it at something like this. We tried to defibrillate, we tried chest compressions. And if you didn't attempt it, you just mark Y. Witnessed by a lay person, somebody saw it happen. If you hit yes on AED, it's going to ask who did it. So it's going to be a non-EMS healthcare provider. And then if you got ROSC, it's going to ask when that happened. And it happened when we get to the emergency department. If you discontinued, you're going to mark when that happened and the reason. In this case, we didn't discontinue. And here's what happened. They died. You can fill out some of these if you like. I think they're handy. Here is the cardiac rhythm when you arrived at the destination. It's fairly important. By the time we got there, we were pacing them. CPR, you're just going to add it. Personnel did a very good job. And since it happened by us, we just save it. If it was given prior to EMS and you set the time as prior to EMS, that gives this option, and you can say a layperson did it. And then you can say we did it. And actually, I made a terrible mistake. In this case, it would not have been Roman. It would have been just nobody. Boom. So you see we don't have the prior to EMS section. And now you mark everything that you did. Very right? Compressions with a plunger, compressions with ventilation with a VBM, and then ITD. We don't have those, but you never know. Any additional info you can use if there was a ROSC time. These actually don't have options, so you don't need to fill them out. Outstanding. Medical history. None. So I'm going to go back and delete some of this so we don't get errors from it. Because sometimes you'll get errors from those things if there aren't other cardiac arrest things happening in the report. Stop being rude, man. See, it's lanky and rude. Perfect. So normally it would just look like this and you'd feel happy. Perfect. Here, medical history. If there were barriers, you're going to put them in, whether they psychologically impaired or a language barrier is probably the most common. And then any indicators of drugs or alcohol. They wouldn't talk to you about it. I smelled the alcohol. They admit to it. I saw some paraphernalia or drugs containers. You can document that here. You say who I got this from. These are extra things you can do that I think are helpful. Any allergies that they talked about. Guar gum can be really hazardous. Medication allergies, if you know about them. Serum and vaccine. Anesthetics. Advanced directives, if they're there. If they ask you to do not resuscitate, but there are no documents, you would check that. There's a living will, state the MNR. That's what we hope we find in those cases. Medical surgical history, and pretty much on all cases, you'll just say see the narrative. You can do this if you want. Possible unconfirmed. Oh God, I hope not. Emergency form, that's not something you're going to fill out. And if you want to put the last oral intake, you can. You don't need to do immunizations, current medications, practitioners, or the medical history narrative. Some people do use the medical history narrative, and that's fine. Your medical history for your patient either needs to be here or in your standard narrative, one or the other. You can also do both so long as they match. Narrative. So like I said, best practice is to put this in Word and paste it in. It's worth noting, you'll see that when I right click, I don't have a paste option. That means you have to hit Control V. V is in Victor. Control is the bottom left button on your keyboard, and then V is in Victor, and that will paste it in. Works really, really well, and you'll get whatever it is you typed out there. This is my narrative template. It doesn't have any information right now, but that's what it looks like when you paste it in. Then you do vitals. Hit a new set of vitals. Pick the time that the vitals happened. So we arrived there at 15:30. So hopefully by 15:31, we had a set of vitals taken, depending on the patient. It was taken by my friend Joe Billings. This is where you would say, I missed the vitals because of these reasons, right? Anything that isn't here, it's because the guy was just not playing nice with me. They were in a sitting position. So you got some different options, car seats, Fowlers, semi-Fowlers, all these different things. Then you put the vitals in. Talk about how you got the blood pressure. Get that first manual one. You can put the mean there if you want to. I suppose the mean arterial pressure is for that. Let's see, a little bit of math. What is it? It's probably really high. Oh yeah, that's alarming. Wow. Okay, that's pretty bad. Great. So you could put the mean pressure if you're measuring that and noticing that, and I really hope that you are, because you're all outstanding EMS providers. You're going to put the pulse rate. You're going to put the method that you took it, whether you listened to it, Dopplered it, maybe someday, whether you took it on the cardiac monitor, some other monitor, the pulse ox, or you palpated it. I always recommend palpating your first pulse, at least. Rhythm, whether it was regular, regularly irregular, or irregularly irregular. And then your BG once you take it. Respiratory rate, whether they were not breathing at all, labored, that is mechanically assisted, either by ventilator or by you, normal, rapid, shallow, or weak. This is your initial room air saturation. Not great. This is the place where you put saturation if they're on oxygen. If you get a CO level, you document it here. End-tidal CO2 is here. Oh, air trapping, that's bad. Temperature. How you took it. Typically we take oral. Fahrenheit, but you can also document in Celsius if you want. And then you have Glasgow. Unable to bleed. Like so. Oh, he's not well. Whether you did a stroke scale, I like to mend myself. Whether it was positive, negative, inconclusive, unable to complete. This is where you put a pain score. Rather typically we will put the numeric. You can do the Wong-Baker though if you want. We don't use this. Level of consciousness. Then if you did take an ECG tracing, you can talk about what kind it was, whether it was a 4-lead, a regular, normal, left-sided 12-lead, a right-sided 12-lead. There's nothing here for posterior, so I would just mark it as right-sided typically. 12-lead, I manually interpreted because we're all skilled providers and can do that. I saw some things that were kind of scary to me. You're going to mark everything that you saw as applicable in that particular tracing. Then you save it. Now in a few minutes, probably about, on that patient, I'm going to guess 5 minutes later, 15:36, we're going to have taken another set of vitals. And in this case, things are getting a lot better. Because of the excellent treatments that you did. Just amazing, amazing work on everybody's case. I just can't even believe how good this person is now doing. Wow, we really saved them. That was beautiful. 5 minutes made the difference. We don't use lab. We don't have that. If it's a child, the OB Pediatrics will be available to you. We can't get into it right now. It's just got a few little drop downs that you can enter in about either the childbirth situation. It's got things like AppGARS or the pediatric stuff. Interventions, this is where you put everything that you did. So all the stuff that you did to save this person's life, you put in order. 15, 31. We probably started an extremity IV. Oh, maybe we did an EJ. That would have been cool. Would have been real cool. Only took one attempt. Popped a 14 in there. It was successful. That improved the patient's situation, and that was probably performed by the chief there, the paramedic. Fortunately, he did start to bleed, so that was a bummer, but that's all right. Then typically you'll choose some site that's normal, the ACs. You can use foot, hands, forearms. In this case, it was a left EJ, which is amazing. And then you write what authorized you to do that, whether it was your protocol or whether you had online medical control or a written order in the case of an IFT. This is a protocol thing. And you don't need to fill out this down here. That's where you would put the physician online. We don't use that. If you did an IV, the IV tab opens up. You're going to say what type it was, what it was for. Typically, it'll be a peripheral. You can also do a saline lock if you want, but peripheral is your most common. And then you choose IO for interosseous access. Catheter length, unless you're using some sort of a weird catheter, 1 1/4 inch is your typical. Actually, I think the 14s are longer than that. I should go look at them. Then your fluid weight rate, whether you gave them a specific drip rate or you did it wide open. Then what you gave them and how much. So I gave them lactated ringers, and I bolused between 500 and 1,000. Nailed it. Other procedures that exist that you probably want to know about. We don't need to use these in and out of district base anymore. So if you BVM'd somebody, if you CPAP'd them, if you tubed them, if you needle cranked, any of that stuff. We don't do arterial cannulation. We don't have to do assessments anymore because we do bundle billing. If you did any, we don't do transvenous spacing. If you applied a cervical collar, decompressed the chest, childbirth, started compressions, defibrillated them, Heimlich, hemostatic agents are here, laryngoscopy, put on those mask pants that we're carrying, occlusive dressings, if you put PEEP on them, if you warmed them up, cooled them down, if somebody does precordial thumps, I will take you to dinner. If it's indicated and it works. You can't just go around hitting your patients, guys. It's not cool. Scalp veins are an option. Splinting, remove a taser barb, tourniquets. We don't need to do transport driver anymore. And then your whole vascular access section, vagal maneuvers, wound care. So you have a bunch of options there. So put all of your interventions that you did. Over here's medications. This works very similarly. You're going to choose the time, 15, 30, 2, 30. After we got that EJ, we gave some medicine. And now here we have a ton of options. Typically, you just want to search for what you want. So if you want to find fentanyl, there it is. If you want to find oxygen, there it is. If you want to find hydroxyzine, there's that. These are things that you would give them. But of course, since all of my ailments got 100% better, we know that what you gave me was ketamine. So medication authorization was by protocol. We gave that intravenous, but you have a couple options, whether you can give it intramuscular here, intranasal, intraosseous. Some of these we don't do, like intraocular. I really recommend we don't experiment with that. Nebulized medications, oral for things like oral glucose. Sublingual. Oral is what you would use for an orally dissolving tablet like Zofran as well. And that's pretty much all of the routes that we're going to be using. So in this case, it was an intravenous. And naturally, because of my size, let's see, we'll do a little bit more. Well, why not? Let's just give all 500 milligrams. No reason to waste any. This is where you document whatever you wasted. Make sure you get your units correct. And the response, whether that made things worse, better, or they didn't do anything at all. In this case, it improved things a lot. Of course, in this particular case, thanks, Chief. I really appreciate that. Complications. There was a little bit of a brief apneic period, but that was transient and went away. Overall, really a good intervention. You can document airways here. Pretty simple. Document methods that you use to confirm them. Actually, this isn't working right now. Don't use this. Don't use that. This is where you document why you did it. They were not breathing. And they had a little bradycardia, but it was okay. And the reason it didn't work, this is your excuse section, is because they weren't relaxed enough. We don't use medical device data at this time. And we don't use the protocol section. Outcome. Disposition. Did they refuse care or did we take them? Sometimes you can use some of these other ones if they apply. If you treated them, they transport POV or LE, stuff like that. In this case, we took them. Destination, where you ended up. You have a whole bunch of lists. Took them over here. This was a hospital. Sometimes you take them to a non-ER bed, especially on IFTs. We have done medical offices and clinics and things of that nature, but most often it's an ER. Number of patients, just this one. On the way to the hospital, it was kind of a big deal. So we rode fast, but that's where you would put all how you went to the hospital. Transport mode, whether there's a wheelchair van or a different type of ambulance. Just choose your default here. We moved them from the ambulance in a stretcher, but sometimes they can walk. Sometimes it's a wheelchair. It just depends on what's going on. Moved them into the ambulance over here. We carried them, and we also used a stair chair. Patient transport position, it was pretty much semi-Fowler's the whole way. Final patient acuity, it was pretty bad by the time we got there. Transport mode descriptors, you don't really need to mess with this. Most of the time, your destination choice is going to be protocol. On occasion, you will have to do diversion. If there's a family choice component in your clinical judgment, you can document that here. Sometimes patient's physician choice is part of the game as well. Instructions, this is if you gave your patient instructions specifically on refusals. You can say, I told them this, I told them that, things of that nature. Don't use this. Good. Additional information. This is where you just confirm that the authorization is correct. You don't do signatures here yet. Miscellaneous, not much use of this at this time. Documents, this is where you'll upload your documents. You're going to hit import, and you're going to go find your documents, which will be in your scan folder. From there, I'm not going to open any of these up because I think there's HIPAA stuff in there. But once you find the thing you want to use, you're going to choose it. Let's see, I think there's got to be something cool here. Yeah, training report, that'll work. You're going to use the existing file name, or you can choose it right there. Hit OK. It'll upload it. Now, if you want to view it, you can open it up, make sure it looks the way you want it. Outstanding. We don't have any custom checklists right now. You could document an exposure here, but and that's okay, but make sure you do an exposure report using the exposure report form available under EMS documents on a lab tech as well. Cancel, we don't need to do that. Perfect. At this point, you're going to save this and wait for a moment. What it's doing is a NEMSIS check. You don't need to click the NEMSIS check button. When you save it, it saves all the data and does a NEMSIS check. Uh-oh, errors. Danger. Whoops. Pregnancy cannot be selected for a male patient. Check patient gender. Okay. Right. So I can double click that and it'll take me here. I'll be like, okay. Never mind. Kidding. My bad. Additional response mode descriptors, not applicable. Okay, what happened here? Oh, I can only pick one of these. That's good to know. I didn't know that. Once you fixed everything that gets mad about, this is a very important line. Data has been saved to make sure that happens. And you're looking for 0 errors. So just resolve everything it asks you to resolve. Make sure your data has been saved. If it does not say data has been saved, don't close out of this because you'll lose everything and that'll make you sad. I don't want to see you sad. Then you close this. At this point is when you fax. You're going to hit print. Choose your fax machine. And that'll have your send fax screen here. Then you're going to put the fax number. That's all right. Fax number of the hospital. That's Grand River's fax number. I'm not going to send that because that'll be very confusing to them. And it'll send that over to them. That's something that you should do as soon as you've finished and verified the report is complete. Then you're going to hit NFIRS. Do an NFIRS check. Oh no. We have to have an arrival date. And the arrival date time cannot be later or earlier than the alarm. Okay. So let's go find that. Perfect. Kind of auto-populated. That was cool. Let's try NFIRS again. Still having this problem? Oh, I think it's because it's the same. Let's say that it's a little later. So again, this has to be in chronological order. A lot of errors come from times not being in order. It can be a real problem. It's going to kick my butt, I guess. This is the part where you call for help. Let's make sure it's saving, shall we? This is a good opportunity to to witness a troubleshooting. I wonder if part of this isn't here. Let's fill in some of this, shall we? I'm pretty fast out the door, is all I'm saying, you guys. That's all I'm saying. And man, I don't spend a lot of time on scene. I'm fast. This was right near the hospital also. Oh look, it even knows that that's not going to work. I mean, it's not in chronological order. That'd be rude. 55, 20, 20. Oh, yes. So you see how easily this can become a problem. Beautiful. Let's see how it likes that. Hey, this is what you're looking for. NFIRS check is complete. Now you close the form. And you click it and you hit review. You're going to bump it up to level 1. Click here and hit ready for review. Here's where you want to document NEMSIS and NFIRS checks complete. Fax to Valley View Hospital, wherever you faxed it. That's where we document that happened and that you checked these things. Save it. Close it. Move on with your life. Enjoy your day. Thanks for watching.